Okay, this is where I left off last time. And let me just recap this. And what we're looking at here are three blood pressure tracings. These are arterial blood pressures. And these were the experiments that were used to identify the fact that there are alpha and beta receptors, and that was done through recognizing what was called an alpha effect here versus a beta effect down here on the bottom. And so just to reorient you to this slide and see what kind of information that we have up here. So each one of these little peaks, right, is an individual contraction of the heart, right, and it's the pressure wave that results from it, all these whole bunch of contractions of the heart. The height of the pressure wave indicates systolic pressure, in this case 145, and the bottom of the waves indicates diastolic pressure, in this case 100. And heart rate is achieved by counting the number of beats there are per minute of time. The paper, this is written on paper, and the paper is rolling under a pen at a fixed rate, and so we know how fast the paper is moving, and so therefore we can count the number of beats that occur in a minute. We can also calculate from this pulse pressure, which is the difference between systolic and diastolic pressure, shown here, right? And we can calculate mean arterial pressure, right? And so we're looking at these. These were experiments, again, that were done in dogs, where these arterial pressures were recorded under three separate conditions. And in one conditions, the animals were administered a dose IV of the drug phenylephrine, and here's its structure right here. Phenylephrine in the first one, and epinephrine in the second one, and there's the structure of epinephrine, and isoproterenol in the third one, right? And the drugs were all administered at the points that is indicated by the arrows, right? And you see effects of the drugs by, in the first curve, you see a change in blood pressure, right? Where systolic pressure goes up, it goes from 145 to 190. Diastolic pressure goes up too, from 100 to 145. And pulse pressure does not change. Pulse pressure being the difference between systolic and diastolic, it doesn't change. The pulse pressure is 45 over here at this point, and 45 over here at this point. So pulse pressure didn't change. And the heart rate actually went down, right? The heart rate started at 170 and went to 160. And the nature of this, the character of this effect was deemed as the alpha effect. If we look at the bottom tracing, we see what's called the beta effect, right? And one of the most notable things that happens in the beta effect is that the mean arterial pressure falls if we're calculating or estimating mean arterial pressure to be at about this rate. We see that it falls and then it comes back a little bit, but it's still depressed. Mean arterial pressure is down. Heart rate is very much increased. It goes from 150 to 240. All right, so that's a huge increase in heart rate, 90 beats per minute increase in heart rate. So the heart is really beating here. The systolic pressure drops, right, from 145 to 95 and then recovers a little bit to 130. And the diastolic pressure really drops from 95 to 28 and then recovers to 150. So you could say that this portion is the original, this is the drug effect, the pure drug effect, and then from here out, this way is some reflex compensation. So, and this was called the beta effect, right? And both of these drugs are structurally pretty similar. This is isoproterenol here, and this is phenylephrine here, and pretty similar. And then epinephrine causes effect that's kind of a blend of both these two, but the separate nature of the top and the bottom curves were denoted as the alpha and beta effects. And it was assumed that, well, these are different drugs and they're acting on different receptor populations in the cardiovascular system. And indeed, turns out they are. So if we look at the phenylephrine, one of the most notable things that we'll see about this is that all these pressures increase. All the systolic increases, diastolic increases, mean arterial pressure increases. That would indicate that. What would you think that would indicate that this drug is doing? Right? What's the primary target of this drug effect? And there's a hint in that heart rate slows. Right? So where this drug, phenylephrine, at this dose, the effect is predominantly due to, is predominantly due to vasoconstriction. Right? And so the blood vessels, the arterioles, are really constricting, getting narrower, making it harder for blood to flow through, and so blood pressure rises as a result. Right? So this increase in all these pressures is due to vasoconstriction. And what about the decrease in heart rate? There's a question about whether or not that's a direct effect of the drug. Is the drug directly slowing the heart while blood pressure is increasing? Or is this a reflex compensation that's mediated by the baroreceptors? And it turns out the latter is the case, that the blood pressure, the heart rate is dropping because of a reflex. The baroreceptors are set off because of the increase in blood pressure, and that feeds back parasympathetic stimulation onto the heart to slow the heart rate. And I'll show you a slide coming up that provides evidence of that. All right, so the alpha effect then, for drugs administered at this dose, for phenylephrine administered at this dose, produces predominantly vasoconstriction. Right, and that was the interpretation of all these changes in pressure, and a reflex decrease in heart rate. So let's look down at the bottom one with isoproterenol. Right, so this one, the first thing is isoproterenol increased heart rate from 150 to 240. Now that's a huge effect, and that was thought to be a direct effect of the drug. Right, so the drug is stimulating what came to be known as beta receptors on the heart to produce this beta effect. But you also see a decrease in mean arterial pressure, so the heart is going a lot faster, and cardiac output must be increased by this, massive increase in heart rate. Cardiac output is going to be vastly increased, but it does so in the face of decreased resistance to blood flow, seen in the fact that the pressures drop. Right, so the blood vessels are dilated. So this is an increase in heart rate, is a beta effect, and then this, which apparently is vasodilation, is also a beta effect, vasodilation. All right, so these are both beta effects, and these are the predominant findings from the study, noticing that the big point is that there's a beta effect and an alpha effect, and the assumption at the time that this experiment was done was that there are two different receptor populations that are responding to these drugs that are all phenylethylamines, right? Phenylethylamines, but these drugs are able to select between distinct receptor populations to produce their effect. So we would say that phenylephrine is predominantly an alpha drug, and isoproterenol is a beta drug, and we still call them those. It's still what we call them today. And epinephrine is a mixed drug. It produces some alpha and some beta effects. So I talked about this figure for a long time, and there's a lot to digest here, and spend the appropriate amount of time with it. So this is from your textbook, and this is the type of figure that's presented in other textbooks. Goodman and Gilman and other textbooks use a figure similar to this, and this shows essentially the same information with the alpha effect on this panel and the beta effect on this panel. and the drugs used are not exactly the same. Remember, this one is epinephrine, right? So an infusion of epinephrine will produce an alpha effect, and that's a very dose-dependent phenomenon. You have to pick the right dose to get the alpha effect of epinephrine, and but you don't necessarily with isoproterenol. And there's the beta effect again, which will this one shows a slight increase in systolic pressure. The other one showed, the previous figure showed a decrease. Doesn't matter. The big thing is that pulse pressure really increases, mean arterial pressure goes down. This one, mean arterial pressure goes up, systolic pressure goes up, diastolic pressure goes up. And here they've included a calculated value for peripheral resistance, right? So they calculated peripheral resistance, showing that the resistance to blood flow is greatly increased by this dose of norepinephrine, and this is due to vasoconstriction, where if we look at the third panel, the corresponding peripheral resistance is greatly decreased, and that's due to vasodilation, right? A decrease in peripheral resistance. So it's essentially the same information that's on this figure and the preceding figure, right? But again, this is how alpha and beta effects were first identified, and it was first hypothesized that there must be different receptor populations mediating the two distinct effects, and they turned out to be correct, right? So I said that there was some question about whether or not that alpha effect, which caused a reduction in heart rate, let's go back and look at that. This slide addresses the fact, this is evidence that shows that it was a reflex-mediated bradycardia due to the alpha receptor stimulation. So let me go back over here to show you what I'm talking about. So here's the alpha effect. The top tracing is the alpha effect. And you give the drug here, and you see these increases in blood pressure, and the decrease in heart rate goes to 160 from 170. The heart rate slows down. And the question was, is that a direct effect of stimulating alpha receptors on the heart, or is that a reflex mechanism because the baroreceptors have been activated? So you remember the baroreceptors, right, are located in several parts of the body. They're in the arch of the aorta, they're in the atria, they're in the carotid bodies, they're in numerous locations around. And when blood pressure goes way up, the baroreceptors, as you will recall from Dr. Pond's lectures, the baroreceptors are then activated, and they send signals up to the brain, and then the brain then turns on the parasympathetic stimulation to the cardiovascular control centers, to the heart specifically, to increase parasympathetic flow to the heart, to slow the heart back down in the attempt to normalize blood pressure. And so here's this first panel, the one on the left, is a replication of the dose of phenylephrine here, which we saw produced the alpha effect, and a small dose was given, and it caused a brief increase in blood pressure, right? Mean arterial pressure is going up, systolic pressure is going up, diastolic pressure is going up, right? And it's a small dose, and you get 75 micrograms is a small dose, but it's enough to see this little brief effect. And just lagging behind this increase in blood pressure, this tracing up above, this one right here, is an overall tracing of heart rate. So they've got a machine that counts the pulses, and it draws a line that indicates what it thinks the heart rate is at any one given time. And lagging just behind this increase in blood pressure right here, we see a decrease in heart rate. So the question is that the drug effect or a reflex effect? So in order to test this, they repeated the experiment, but this time they treated the animal with mecamylamine, right? And so mecamylamine is given as a pre-treatment over here. All right, so the animal is injected with mecamylamine, it's allowed to circulate and have its effect, and then phenylephrine is added to see the increase in blood pressure again. And remember that the mechanism of mecamylamine is that this is a ganglionic blocker, a nicotinic receptor blocker at the autonomic ganglia. So this mecamylamine is essentially shutting off any autonomic nervous system reflex response that would have occurred, because that reflex response comes from the brain through the parasympathetic neurons into the ganglia, where acetylcholine is released onto nicotinic receptors, causing the postganglionic neuron to then develop action potentials to carry down to the organ. And this drug blocks neurotransmission at the ganglia, and it also blocked the change in heart rate. Right. So the conclusion was then that this bradycardia that is occurring as a result of this vasoconstriction right here, right, is a reflex response, because you can essentially sever or cut or block the pathway for reflex responses by blocking the autonomic ganglia with mecamylamine, right? So that this was a clever experiment to do, and a clever finding, and worth putting on the test. And I hope you learn this and understand. And if you don't, come to the review session. Remember, this is exam 3. Come to the review session and ask questions, and I'll be happy to explain this again and these figures again as well. Okay. So to summarize what we've seen so far is that the alpha effect, right, is seen with either a relatively low dose of norepinephrine or a dose of phenylephrine. And what you see is an increase in systolic and diastolic pressure, which is mediated by what we now know are alpha-1 receptors that cause vasoconstriction, and that there's an associated reflex bradycardia. The heart slows down because of reflex. That let me skip down here to the pure beta effect with isoproterenol. The pure beta effect is that you see systolic, you see an increase in heart rate and strength of contraction. Remember the pulse pressure, which indicates the strength of contraction of the heart, was greatly increased, and the heart rate went up to 240. So that was a beta-1 receptor-mediated effect, and the diastolic effect was reduced due to the decrease in peripheral resistance, right? And the mean arterial pressure, diastolic and the mean arterial pressure as well, were both reduced due to a reduction in the peripheral resistance due to vasodilation, right? This is vasodilation, which is a beta-2 effect, right? So vasodilation, beta-2, cardiac stimulation, beta-1, vasoconstriction, alpha-1, right? And those are things that you'll need to remember. And then norepinephrine or epinephrine produces intermediate effects. You see some the systolic effect is seen due to an increased strength of contraction, an increase in pulse pressure, a chronotropic effect, an increase in heart rate. This is beta-1. And then direct effects of the drugs acting on beta-1 receptors to cause the tachycardia. You saw the tachycardia down here as well with isoproterenol. Tachy, fast heart rate, tachycardia. Sorry for the sloppy spelling. Tachycardia, right? We saw that as well. And then we did see some decrease in diastolic pressure due to vasodilation and a reduction in peripheral vascular resistance, which we say is mediated by beta-2 receptors, similar to this down here. All right. And all of these occur at particular doses, and I'll show that on an upcoming slide. Right. So this is a summary of the alpha effect, just emphasizing the alpha-1 effect is vasoconstriction and a reflex bradycardia, and that becomes clinically important with some drug use. And then to the beta effect, we see beta receptors, tachycardia, an increase in systolic, increase in an inotropic effect and a chronotropic effect. Right, heart beats harder, heart beats faster. That's beta-1, and reduced peripheral resistance or vasodilation, beta-2. And those are the take-home messages from here. So we're going to look just a little bit, we'll be talking a little bit more about these vascular effects of these because these drugs are, epinephrine, for example, is used as a drug. Norepinephrine is used as a drug. And so predominantly what we're seeing with the beta-2 effect is relaxation of the smooth muscle that lines the vasculature here, and an opposing alpha-1 receptor mediated effect causing contraction of the smooth muscle, which this would manifest as vasoconstriction. All right, and so this is going to increase blood pressure. Right, that's going to increase blood pressure, and this is going to essentially decrease blood pressure a little bit, but at the same time, you usually get a stimulation of the heart muscle. All right, so just bear that in mind. And this figure goes with the next figure right here. And what is shown here is, if you look at the y-axis, is does the vascular smooth muscle relax, right? Does it, you see the beta-2 effect, or does it contract? That's the alpha-1 effect. And what happens as a result of how much norepinephrine, could be epinephrine as well, how much do you give, right? So there is a dose-dependent effect of the vascular smooth muscle on, it depends on how much of the norepinephrine or epinephrine that you give. At low doses, what you first see is vasodilation, relaxation of the smooth muscle of the vasculature, and that is due to the beta-2 receptors being activated. They have a higher affinity for epinephrine and norepinephrine than the alpha receptors do. But as you keep increasing the dose, what happens is then the drug starts binding to the alpha receptors, and the alpha receptor predominates, right? So it goes from vasodilation, it changes over to vasoconstriction, because in the first instance you're stimulating beta-2 receptors, and then the second you're stimulating alpha receptors, and the alpha receptors will win out, right? Their response is at higher doses stronger than the beta receptors. And the dotted lines say this is the beta-2 response, and if you had blocked the alpha receptors, this is what you would see at all doses of norepinephrine or epinephrine. You'd see these responses. And conversely, if you blocked the beta-2 receptors and then gave norepinephrine, you would only see the alpha response here. Right? So this is the alpha-1 response. Alpha-1 vasoconstriction, beta-2 vasodilation. Okay, and that takes a little time to digest what I'm saying there, but it's all correct. It all makes sense. You just have to appreciate that the blood vessels have alpha-1 and beta-2 receptors on them, and if you stimulate the beta-2 receptors, it causes the muscles to relax, because the beta-2 receptors are connected to one signal transduction mechanism, and the alpha receptors, the alpha-1 receptors that are on the same cells, are connected to a different signal transduction mechanism that causes contraction. Right, so you get differential responses. You can get a different response with the same drug depending on the dose, because the affinity of the drug for the receptors is different, and that's the case with norepinephrine and epinephrine. And this has some clinical relevance, as we'll see. All right. So this slide represents a real change in sort of orientation of this material, and it does so in the fact that we're going to start looking at these neurotransmitters and as drugs, right? So as I said previously, this may be a good time to just stop, and if you need to review what I've covered in the first part of this lecture, and then the lecture for yesterday, all right, this would be a good place to just stop the tape, go back and review, all right, because we're kind of moving off in a different direction, and we're going to talk about these things as drugs. So I'm going to give you permission to hit the stop button here, but if you want to go on, you're ready to go on, let's go on. So norepinephrine is used as a drug, right? And it acts as an agonist at both alpha receptors, mostly alpha 1 receptors, and at beta 1 receptors as well. So this is what you see clinically. And the alpha 1 receptor response is vasoconstriction. And this is seen first at lower clinical doses, and it persists as doses increased. All right, and these low doses are higher than what we saw on the previous slides. When you use norepinephrine as a drug, you immediately give sufficiently large doses that you miss that beta 2 effect, and you're on into the alpha effect on the vasculature. So norepinephrine as a drug is predominantly known as a vasoconstrictive agent, right? And it's a powerful vasoconstrictor. And then as the dose increases, then you start to see beta 1 effects at the heart. And the beta 1 effects on the heart are to increase the contractility and heart rate, so the heart beats faster and it beats harder, and the conduction velocity across the heart increases, right? And we would say that these are positively inotropic, positively chronotropic, and positively dromotropic effects. So these cardiac effects are seen at even higher doses because remember the baroreceptor effect that kicked in that showed the decrease in heart rate due to the reflex mechanism with norepinephrine in one of those previous slides. So what I'm referring, let me skip back to it right quick. Let's see. Let's get back to this, right? That decrease in heart rate is shown right here. This reflex decrease in heart rate, that's going to occur. So that will mask the stimulatory effects of norepinephrine activating beta 1 receptors on the heart. So to see the cardiac effect, you have to push the dose higher to overcome the reflex bradycardia that the parasympathetic nervous system is trying to impose on the heart. So, but you can do that. You can push the dose up, and it will start to stimulate the heart. But this is clinically a dangerous situation. When you are increasing cardiac output, in other words, you're forcing the heart to increase cardiac output, but you're doing it against a wall of vasoconstriction, the stress on the heart is considerable, and most patients receiving this drugs are going to have some sort of compromised cardiovascular function to begin with, and this is a dangerous combination. And as a result, there's pretty limited use of norepinephrine as a clinical agent. Right, the joke, an old joke, is that the brand name of this was called Levofed, right? But in the clinic, it was jokingly referred to as lethal fed, because it was a fairly dangerous drug. All right, let's do a couple of more before we quit. The second drug is extremely useful clinically and is used frequently as epinephrine, right? And epinephrine is an emergency drug. At low doses, you see predominantly beta effects, right? It's cardiovascular stimulatory and maybe a little vasodilating, but at higher doses, you start to see the alpha effects as well. Those are added on. And the alpha effects, again, are vasoconstriction mediated through alpha 1 receptors, and positive effects on the heart for inotropy, chronotropy, and dromotropy. That's increased strength of contraction, heart rate, and conduction velocity. Those are predominantly mediated by beta 1 receptors. And then you see some other effects outside of the cardiovascular system. You see a beta 2 agonist effect that causes bronchodilation, right, which usually makes it easier for the patients to breathe because it opens up the airways. There's effects on skeletal muscle to increase contractility and other vascular dilating effects, which may be positive. This drug will also cause hyperglycemia because of, sorry for doing this to you, these little details, but an alpha 2 effect, which decreases insulin release, a beta 2 effect, which increases glucagon release, and that stimulates gluconeogenesis and glycogenolysis to drive blood glucose up, and it also stimulates lipolysis and fatty acid release. So all this is getting energy levels of carbohydrates and fatty acids up in the blood right? Because remember, epinephrine is an emergency drug, and it's making energy stores available for use, right? So epinephrine is often used as an emergency drug in treating anaphylactic shock and possibly other forms of shock, where shock is just as a general word, shock means that blood pressure has fallen too low to uh, to be consistent with extended life, right? It's a life-threatening drop in blood pressure. An anaphylactic shock shows that other types of shock do as well. Neurogenic shock, in other words, if a person has been subjected to some violent physical trauma, like falling off a tall ladder or being in a car wreck or something like that, that may be a neurogenic shock. And there's a septic shock as well that's due to infections. There's various types of shocks, and which are just precipitously low blood pressure. Anaphylaxis causes that. It also causes a collapsing of the airways and an increase in the effusion of fluids into the bronchial tree, which will be helped by the bronchodilating effects of epinephrine. It's used as a cardiac stimulant in some cardiac emergency. It has been used in asthma emergencies where patients just simply can't breathe because they're having a severe asthma attack. So it's a useful emergency drug. It's also included along with local anesthetics because it will, when it's injected directly into tissues, it causes a vasoconstriction effect, which reduces blood flow. And the local anesthetic is given, by a needle, where you may have had this when you have a local anesthetic. If you've ever been sewn up, had a finger or hand or foot or something sewn up from a cut, you got a local anesthetic, or you had one at the dentist office or something like that. And that local anesthetic will work. It will stay as long as it will stay in place, and its actions are terminated by blood flow coming through the area. So if you give a vasoconstrictor along with that, then that reduces the blood flow and makes the local anesthetic last longer. I said it keeps locals local. Local anesthetics are local by reducing, and it also reduces bleeding due to the vasoconstrictive effects when given locally. Anyway, that's epinephrine as a drug. It's got a lot of utility. And any clinical details that don't trust me for any clinical knowledge. When you get into the clinic with people that are actually using these drugs in the clinics and in the hospitals, they'll tell you what the most current information is and the most current application of these drugs in therapeutic settings are, which is not my area. It's somebody else's area. Dopamine, interestingly, is also available as a drug. It's used in conditions like congestive heart failure, where the heart is failing. It stimulates the activity of the heart. It also stimulates norepinephrine release at the heart. It acts on beta 1 receptors, and often patients that have this compromised cardiac output are not adequately perfusing their livers, and the liver is a highly energetic organ that requires lots of oxygen and lots of nutrients. And when cardiac output is down, the kidneys rather, are likely to be damaged because of the lack of perfusion, and there will be in a congestive heart failure type setting or some other cardiac emergency, there may be a lot of sympathetic activity going on, which will cause vasoconstriction in the kidneys. And dopamine acts to counteract that and improve renal blood flow, which is a notable feature of dopamine, used as makes it a better drug for the use as of a cardiac stimulant during some conditions. And Dr. Stewart will give you the straight story on that as well. So dopamine itself. And dopamine, epinephrine, and norepinephrine are all drugs that are only administered by injection. You can't take these drugs orally. You could, but they wouldn't have any effect. And they wouldn't have any effect because they would all be digested or metabolized by the catechol-O-methyltransferase that we talked about previously, which is found in the intestinal epithelial cells. right? And so they prevent these drugs from being absorbed from the GI tract. They metabolize them quickly. So all these drugs are given by injection. And I think I'm going to just stop right here. I feel like that's enough for one lecture and give you all a break. And I'll pick this up with tomorrow's lecture right here.